the adrenal gland are seen as life-threatening conditions, especially when presented with hypokalemia, a prime reason for fatalities. For perinatologists and obstetricians like myself, the interface of adrenal gland disorders and pregnancy is a topic of extreme importance. That's partly because some symptoms overlap. For instance, arterial hypertension presents in both hyperaldosteronism and preeclampsia. Another quandary is that many diagnostic tests performed for adrenal disorders are forbidden during pregnancy. Among those is the adrenal venous sampling, which helps determine the nature of hyperaldosteronism. Is it bilateral or unilateral? Is it primary, like Conn syndrome, or secondary, caused by pituitary disorders or extraneous conditions like tuberculosis, meningococcal sepsis, viral infections, etc.? By conducting medical research, I prioritize the process of confounding, which is at the heart of epidemiology. In clinical practice, I prioritize differential diagnostics. In the case of pregnancy with Conn syndrome, heightened skills in differentiative analysis should be unyielding. The trick is that normal pregnancy itself can increase renin and subsequently increase aldosterone levels, resulting in secondary hyperaldosteronism. On the other hand, Conn syndrome, which is primary or autonomous hyperaldosteronism, can mimic preeclampsia. Both present increased arterial pressure, especially diastolic pressure at the Korotkov sign 5. So, if you have a hypertensive pregnant patient with a history of Conn disorder, you need to determine the causality of hypertension. Is it solely from Conn syndrome or there is also preeclampsia involved? For instance, low potassium levels of hypokalemia is the key to Conn syndrome, together with hypertension. Although preeclampsia is not known for hypokalemia presentation, still the high progesterone state in a normal pregnancy activates the mutated mineralocorticoid receptors, causing sodium retention and potassium wasting, leading to transient hypertension and hypokalemia. And this is where a skilled clinician would appreciate that progesterone-induced hypertension in pregnancy without preeclampsia must be hypervolemic due to sodium retention. By contrast, hypertension in preeclampsia typically is hypovolemic due to vasoconstriction. Of course, we treat the patients on the case-by-case basis, considering that glucocorticoids can also be involved with increased insulin resistance, making disease differentiation even harder. But there is another distinctive feature to separate the causations. That's the pattern of hypertension. Preeclampsia symptoms start after the 20th week of gestation and may last up until 6 weeks postpartum, whereas hypertension in Conn syndrome can have a wide range of onset prior to pregnancy. Further, proteinuria, disseminated chronic coagulopathy, or elevated liver battery, LDH, and transaminases, AST, ALT, or intrauterine growth retardation that are determinative symptoms of preeclampsia are not typical to Conn syndrome, again, unless there is a comorbid that must be ruled out. Lastly, preeclampsia is known for oliguria, whereas Conn syndrome is distinct by pollakiuria, frequent urination. So, the list of comparative symptoms is practically endless, simply because there are not two identical cases of pregnancy or primary hyperaldosteronism. Having that said, at its core, this video is about clinical divergence analysis. Slide number 12 is where I have put together the main symptoms of preeclampsia and Conn syndrome, and must note that the list is not exhaustive. Before I will leave you to self-tour, I will quickly break down the skeleton of this presentation, starting from taxonomy of the adrenal disorders, where the primary diseases are generated from the gland itself, and secondary disorders are caused by extraneous factors such as disorders of pituitary gland or meningosepsis or tuberculosis. I trust you know, of course, that aldosterone is produced in zona glomerulosa of the adrenal cortex. Here I show the list of primary and secondary adrenal disorders. Slide 5 explains the anatomical nature of Conn syndrome. Further, the genetic variances are reported. Then comes pathogenesis and diagnostic tests, including mathematical modeling used in texture and image analysis. Then I list the diseases that should be differentiated from Conn syndrome. Here is the key slide. Okay, now the management of pregnancy and postpartum with Conn syndrome. Conventionally, the medical section is followed again by the common law analysis based on the 2 published court opinions of relevance and, of course, authentic review questions that I developed without using others' ideas. Those are followed by the answer key on slide 29. Ready? Let's go!